You hear back from a lot of clinicians. They come back and say, "Hey, this was really great. It was really interesting. I never would have imagined that this might be going on with my patient, or these are discussions that I never would have had with my patient, but they were so happy that we did, and it was facilitated by doing some of this measurement using this screening tool." Having this opportunity to kind of open up a window into how they're feeling or how they're experiencing pain can sometimes facilitate these conversations that they wouldn't have otherwise.
Welcome to Orthostatic, the podcast where we dive deep into the most pressing issues in orthopedic physical therapy. I'm your host, Jim McKay, and today we're exploring a tool that's transforming the way we approach patient care, the OSPRO-YF. It's a screening tool designed to identify psychological risk factors that could impact recovery in patients with musculoskeletal pain. And we're joined by some of the brilliant minds behind this tool, Steve George and Trevor Lentz. We'll uncover how this tool came to be, its impact on clinical practice, and how you can integrate it into your own clinical work. All right, so gentlemen, let's talk about the origin story. We want to understand how this thing started. What specific clinical challenges inspired the creation of the OSPRO-YF tool, and how'd you go about addressing it? There needs to be a problem that needs to be solved. Where'd this thing start?
Sure. I'll start with that, and then Trevor can add his perspective, because I think we kind of come at it from slightly different angles. I had been doing some research on the StartBack screening tool, and we had been using it in clinical research and finding it to be very useful. But it was designed specifically for low back pain. So, of course, we were thinking it might be nice to have a tool that cuts across common, musculoskeletal conditions. So you don't have to have, a back screening tool and a neck screening tool and a shoulder screening tool and a knee screening tool. So we started looking at some of the constructs in the StartBack tool, and lo and behold, they act pretty similarly across all of the different pain conditions that we were interested in. So it really provided, I think, the opportunity to see if we could, hammer those together and look at it in one screening tool. The other thing we noticed with the StartBack tool is it focused a lot on negative, if for lack of better, it focused on fear and catastrophizing and anxiety and depressive symptoms. And at the time, the literature is really starting to pay attention to, chronic pain acceptance and self-efficacy. So we wanted the chance to kind of broaden what you were screening for too, so that it wasn't just kind of the negative part of the equation, but you could also get an idea of what the positive part of the equation was in someone's psychosocial profile. So I think from my perspective, those were the questions really driving it: is can we make it a little broader, both in content, and also can we apply it to conditions other than low back pain? And I think the last part is, technically, some of the other screening tools were developed in primary care settings, and we were able to develop and test this specifically in PT settings. I don't think that's a huge issue, because when we've bounced around, you don't see big differences. But from a methods perspective, it was nice that this was developed, with PT. The last part I'll add is, we did compete and we did get funding from AAOMPT to do this work. At the time, it was the section, but it's the same kind of governing body. So that was very helpful, because it allowed us to take our idea and very quickly and cleanly move from a development to validation stage, and gather two pretty decent sized cohorts to do some of the work. To make it, I think, to the point where we were pretty confident that it was going to be a decent tool. I don't know, Trevor, what are your thoughts on that? Did I miss anything?
No, I think it was really all about efficiency and trying to be able to capture a number of different, what we thought are fairly important psychological domains that do have some overlap, but are also in some ways distinct. Things like depression and anxiety. You may not always see those coincide with things like catastrophizing or low self-efficacy. And rather than having to administer a number of different screening tools that I think physical therapists were really interested in using, those just the survey burden ends up getting really, really high for patients and for providers as well. So the efficiency was one of the big things that I think is a draw for a lot of physical therapists and patients as well, is to be able to get a lot of information in a relatively short amount of time.
Yeah, we call it the juice versus squeeze ratio. What are we getting versus what we have to invest in doing that? In the intro, we explained that the OSPRO assesses various psychological factors, and you touched on that. Could you just break down how some of those elements were chosen? You mentioned noticing that there was some negative language in similar tools. So talk about why some of those elements were chosen and why they're critical for physical therapists to consider.
Yeah, we looked at basically, we looked at what had been reported on in the literature. We didn't invent anything. And we looked at questionnaires that were commonly used in the patient populations we wanted. And, we had an upper limit of the burden essentially that we could ask someone to fill out. So they couldn't fill out all possible questionnaires. So, it was an exercise of, there were constructs we were interested in, there were questionnaires that were commonly used to measure them, and really winnowing those down to an item set that we could test. And I think for the yellow flag tool, like 142 or 144 sticks in my brain. And there were about 11 different questionnaires represented. And as I mentioned, fear avoidance, kinesiophobia, catastrophizing, depression, anxiety, anger, self-efficacy, pain acceptance, self-efficacy of pain and the ability to do your rehab. So it's certainly not all encompassing. It's certainly not comprehensive. I still sometimes think about perceived injustice, if we should have included that one, but it was broad enough that we thought we could get everyone's favorite ice cream flavor, or at least you would be able to. It was a shop you could go into and get. It may not have been 31 flavors, but it was 12 flavors, and you were going to be able to find something. You weren't going to go home empty-handed. And then from there, we did a distilling process to get it down to a very manageable tool. So, and then Trevor can comment a little bit on kind of there's different ways to think of those constructs. I'm kind of pushing it back to our original focus on constructs and questionnaires. But then when we get it into moving it away from just being a representation of items from established questionnaires to something on its own, we did some additional testing, and not surprisingly, it stayed pretty true. But I think the way we think of it now is a little bit different. I don't know if you want to get into that, Trevor, with some of the domains, or, how it looks when we test the tool itself, psychometrically.
Yeah, I think from a psychometric standpoint, we originally had those 3 different domains that were fear avoidance, more of a negative mood domain like depression, anxiety, and anger, and then something that represented a little more positive affect or positive coping. And what we've seen, I think, with a lot of the psychometric analyses that we've done this a couple of different ways, is that it seems to be fairly consistent that those domains that were theoretical, at least when we were developing it, seem to play out when we look at it a little bit more analytically. So I think that's really helpful. And it actually may go into some of the stuff we can talk about a little bit later about what we've done since then, and development of new tools or sort of second generation tools, because those, I think, are domains that are really important for physical therapists to consider. One of the things I'll add to what Steve mentioned was that in addition to trying to identify some of these different domains, we also kind of kept in mind, well, what are things that physical therapists could intervene on? So certainly, characteristics like catastrophizing, fear of re-injury, fear avoidance beliefs, all of those things sort of fall within our wheelhouse. They're things that we can do something about when it comes to our treatments. And so that was really important as well. In addition to identifying characteristics like depression, anxiety that maybe we can't address directly, but we know can put our patients at higher risk for poor outcomes, or maybe potentially we identify these folks and they need a different type of treatment. So it was not just trying to identify all of the different potential psychological constructs, but things that we felt were particularly important for musculoskeletal treatment.
Yeah, understanding the scope there.
Right.
Trevor, I want to go back to something you mentioned a second ago, which was like efficiency, right? If this thing's 400 questions, to Steve's point, if it's 600 flavors, it's got everything, but there's too much. So how does this streamline psychological assessments compared to traditional methods to give us a better juice versus squeeze or a better efficient? And what impact does that have on day-to-day practice?
Yeah, I think that's had quite a bit of an impact, or potentially could have quite a bit of an impact. As you mentioned, being able to administer 10 or 11 questionnaires, nobody wants to do that. We don't need to do that. So we definitely want something that is a little bit more efficient. I think it's sort of a double-edged sword we've come to find out, because in one respect, it's really great to have all of this information. In another, it sometimes can be a little bit overwhelming. Now the way that the OSPRO works is it estimates what patients would score on 11 different questionnaires. So now I've got 11 different flags or 11 different numbers. And how do I take all of this information and distill it down into something that I can use to make an informed clinical decision? And that I think some people like that. A lot of people don't, and want easier ways to help distill that information. So that's a lot of the work that we're doing now moving forward, is how do you take all of this information that was really designed as a screening tool, and turn it into a method that can help you make better decisions for your patients. And I think that's kind of where we've tried to go so far. That's where we continue to try to move in that direction, is giving clinicians a better sense of how do you take this information and turn it into practice.
Yeah, you mentioned.
Yeah, and I'll just add. Oh, sorry, Jimmy. I'll just add. That's a little different. It doesn't sound like a huge direction shift, but it's like a 45 to 90 degree angle from how a lot of people think of questionnaire development, because efficiency isn't always at the top of the list. It's, right, how precise and how reliable. And sometimes that adds to the item burden. But if you are really just interested in kind of getting what is the center of this patient, estimate across the different things, it's a different mindset. And I credit our statistician, Sam Wu, at Florida. He's now at South Florida. Really helped us, I think, to think a little bit differently about the development of this. And I think the reason you don't see as much efficiency is because there is that pressure to how reliable can we make this? And that does sometimes add to the length, because there are some items that maybe will really help the reliability, but would not help the estimate as much. And we kind of sacrificed that. So I think that just, that is aligned with kind of philosophically where we were. And I guess a shorter way to say that is there are some people that develop questionnaires for a living that would hate this approach. And I think we acknowledge that. And like I said, I'm not saying that to brag or to bravado, but it's just a different direction. Sure. For how these are built. And since a lot of these were psychologic questionnaires, they were built by psychologists who are very much into, my questionnaire develops this construct as best as you can. And that means reliable. And if I need 21 items to do it, I will do it. So I think just wanted to add what Trevor mentioned there, because I do think that's highly, highly relevant. And the flexibility that he mentioned is also not only in, the interpretation, but in the item sets that you want to use. And the item sets do provide opportunities for a little better reliability and some better clarity on the domains too, is what we found. That's the main difference between 10 and 17 items, is the opportunity for better reliability and some clarity on those domains we talked about in the beginning.
As a dedicated orthopedic physical therapist, you understand the importance of staying current with the latest techniques to better serve your patients. With gait analysis, continuing education, and technology, RunDNA is committed to accelerating your expertise so you can help runners achieve their best. Visit rundna.com/AOPT to learn more and get your free ebook, Top 5 Things Running Professionals Need to Know.
You mentioned that P word, right? Which is who researchers, clinicians, everybody has in mind, which is patients. Is there a case where this tool significantly influenced a patient's treatment plan and outcomes? Anything that comes to mind, either in your own careers, or you heard from someone else that, hey, here's an example of how this was greatly helpful?
Yeah, I think one of the nice things about being in this position and helping develop some of these tools is you hear back from a lot of clinicians who are interested in using it. We talk with them about how to do that, and then they come back and say, "Hey, this was really great. It was really interesting. I never would have imagined that this might be going on with my patient, or these are discussions that I never would have had with my patient, but they were so happy that we did, and it was facilitated by doing some of this measurement using this screening tool." And I think, as physical therapists, we're not necessarily trained, or at least that's not the first thing on our mind, is what's somebody's mental health or psychological well-being. It's really more biomechanically or physically what's going on with them functionally. But, having this opportunity to kind of get a window or open up a window into how they're feeling or how they're experiencing pain can sometimes facilitate these conversations that they wouldn't have otherwise. One large scale example is how we're using it here at Duke in our joint health program. It's an osteoarthritis treatment program. It's something that they administer to everyone that comes through the program. And of course, these are people with osteoarthritis. So a lot of them have chronic pain, persistent pain, and high levels of dysfunction. And so what they're doing then is they're using this information that they find. I've actually done some really interesting work with phenotyping and trying to identify certain like mental health phenotypes for patients that are coming in with osteoarthritis, and then developing treatment plans or programs, pathways that patients are sort of put into based on what their mental health profile looks like and their physical health profile looks like. So it allows them to deliver a lot of this quote unquote mental health care, at least as it falls within the scope of practice for physical therapists, alongside traditional physical therapy care, and with a goal of trying to improve outcomes for these patients. And I think anecdotally, we're still doing a little bit of work on whether that results in better outcomes. But one of the things we hear anecdotally is that, again, going to a place where they're having these conversations with somebody who's knowledgeable and has the time to talk with them about their pain experience does a lot for them, even if it's just sitting down and talking with somebody for 20 minutes about their pain experience that no one has ever asked them about, and what it means to them from a behavioral or mental health standpoint. I think we've heard a lot that it really resonates well with patients. So those are just a few of the examples. Steve, I don't know if you have any that you heard.
I think I don't want to charade around as a clinician. Most of mine are use cases that people brought to us. And I think, to follow along with what Trevor said, this is really one of the first things I published and been involved with that people picked it up and ran with it. They didn't wait for us to say, this is how you should use it. We didn't really have an implementation plan. We had a plan to develop, validate, disseminate, and then we were kind of taking a big breath, relaxing. It was kind of cool. We were happy with it. And then in that time, I was transitioning from Florida to Duke, and I met a group of therapists here that were already using it, and they were telling me how they were thinking of using it, which I thought I was like, this is new for me.
Yeah.
I think the other thing that was new, Trevor mentioned it, is to have surgeons championing this. This isn't something that we suggested should be used in the joint health program. They needed a psychosocial measure. There was some familiarity with the OSPRO. We have a couple of surgeons, both in lower extremity like OA and arthroplasty, but also in the shoulder section here, that are very interested in assessing distress, and they started using it, and they, that was again another first. So I think the fact that whatever it was about this, that people looked at it and wanted to use it right away, it was cool. It also made us realize if you're going to do this, we should have been a little better prepared maybe to have an implementation plan. But, a lot of these things you're learning along the way too.
Sure.
And I've been very grateful for the people that have fed us back their experiences, because it's really informed us about, where we might want to go next with this, what some of the shortcomings are. I mean, from the very first time it was published, someone let us know there was an error in the calculation, and that could have been a nightmare if it were out there for a year. But someone let us know within, I think, what was it, Trevor, like a month it was published, and we had just forgot to reverse some signs in the code, and that was easily remedied, send out the correction. But that we didn't know at the time, but that was a harbinger that people were going to mess around with this.
Sure.
And then, they felt comfortable in us letting us know, like this, don't like this, like this, don't like this. I don't want people to think, this is, there's only, but that's the only way you learn, is to hear what works about it and what doesn't work about it.
And the fastest way to find an error in anything is to put it out there, and then you will get feedback. I've learned that the hard way on Twitter.
Yeah, we had many trained eyes on it at that point, and
So let's go to this. We'll talk about future in a second, but let's talk about this adoption. You said people found this, and that's the good and crazy thing about the internet, is when you put things out there, sometimes implementation is you find out you have a great product or a useful tool. When people find it, play around with it, they have access to it, and they tell other people. The word we use a lot in communications is remarkability. But if someone were listening now, what advice would you give to orthopedic physical therapists who wanted to integrate this tool to their clinical practice? You have some people, you heard back from them that have. What might you suggest would their first steps be?
Probably one of the first steps is just get a hold of it, take a look at it, read through it, understand what you're asking of patients, and then pilot it. Try it on a couple of patients. It is, as some of listeners may recognize or know already, is that the way that it's scored and the way that it's used and what it does is a little bit different than most questionnaires. I think that Steve was talking about a little bit earlier, more traditional psychological measures. It doesn't give you this one number that you would use. It actually is more like a calculator. So it estimates what patients would score if they were to fill out full-length questionnaire. So the actual, the way that it's used and the way that the information comes back to you is a little bit different than most tools. So probably the best thing to do is just try it out on a couple of people, or even yourself, and see how that works. We do, back when we developed the tool, we worked with AAOMPT to develop a calculator, a website. And I think if you Google OSPRO yellow flag, it'll be the first thing that pops up. But basically, get on that website, you can enter the information in there and see what it gives you. So it's probably the best way to start it out. And then, the other thing that I hear from a lot of therapists that have used it is just learning how to talk about it. I already mentioned that, patients coming in may not be expecting to get questionnaires about their mental health or their psychological well-being. So how do you get patients to understand that this information is going to help them, and help them to understand why you're collecting it? Because for some people, it can create stigma. They don't like talking about mental health. They don't like talking about depression, anxiety. And so for them to be forthcoming and upfront, it does require a little bit of getting used to how you describe this tool to patients. And then I think that's probably sets you up well for using it. We've actually developed a yellow flag screening framework that was published in JOSPT back in 2021, I think, and it uses the OSPRO as an example of how you can implement yellow flag screening in practice. So that might be the other resource that I would suggest going to. But I know that Steve's also worked a little bit in this area of implementation. So Steve, you have other stuff?
Yeah, I think I agree 100% with what Trevor's saying, is you do have to tinker with it, and like any new tool, right? Because there's some people that read all the direction, but there's no substitute for just tinkering with it. And I think a very basic thing you have to understand, what we've learned, is it is too much to have it be the score estimates and the yellow flag count and a total score. So find out how you want to communicate it in your local environment. All three ways of those are fine ways to use it. They're all correlated. They all tell you about the same thing. But if you want to use it in clinical practice, I don't think you can have it, be three different, outputs, because that's just too confusing. And one of the things that surprised us early on is the yellow flag count, which I think we were thinking maybe not the primary, like I was thinking maybe people would like the score estimates, but the yellow flag count for the people at Duke quickly became something that they could, it's almost like a dashboard of what questionnaires they're high on or not. And it became almost, like I said, like a dashboard. And someone who has quite a few yellow flags, you're probably going to want to have some of these conversations with them. And then I think the only thing I would add to Trevor is there have been some groups that have a specific question, clinical question that they're interested in. And our colleagues at Intermountain Health, they asked me, well, back to the beginning, should we use the start back tool or should we use the OSPRO tool? This was one of my original motivations and I said, well, I don't know, because there's not data. So they had a very specific case use. So they gave their patients both for a while, and then they were kind enough to bring me in to help look at it. I know Intermountain's kind of a unique setting, but I think in addition to piloting it and tinkering it, if you have a specific, like if you're in a system that is a couple yards down the field on using PROs, you might have a natural experiment of, let's use this compared to what we are using now and see which one our clinicians like, which one informs clinical decision-making better. Because if you use it, you don't have to use it forever. You might have a tool that is perfectly fine, but you won't know until you can compare them. And that's what I appreciated about Intermountain Health, because they're kind of beyond the piloting, if that makes sense. And they had I think a specific thing they wanted to figure out. But what I like about Intermountain, it's the clinical question was driving. They didn't contact me because, oh, you published this in JOSPT, good for you, we want to try it out. They were asking me a question that I couldn't answer without data, and they said, well, we can do that. Right. So we'll do the data, and then we'll find out.
Now we'll get to the future. What do you think the next steps are? Research is famous in saying it's a great way. It's a great business model to be in. Is more research is needed, right? What are the next steps, or what might the next steps be in the evolution of OSPRO-YF? Are there any upcoming updates or expansions that people want to be aware of?
Yeah, I think some of it is already here. We were funded a few years back through Focus on Therapeutic Outcomes, Photo, to develop essentially a second iteration of OSPRO, and it wasn't designed necessarily as a replacement. And there's actually some really important distinctions between the second generation of tools and the original OSPRO. But the new ones are called spare tools, and really I mentioned earlier about how there was a little bit of among clinicians that were using the tool, they felt like, well, this is way too much information. I don't need 11 different scores. How do I interpret all this? What they really felt was important was, does my patient have an issue with negative mood? Is it a depression, anxiety, anger type of issue that maybe I can't do anything about in PT, but may require referral, or it may impact their prognosis? Is it more of an issue of pain coping skills? That I need to work on them. So it doesn't necessarily matter if it's catastrophizing or kinesiophobia, but do they need help with pain coping? And then, is there an issue with some of the more positive characteristics like self-efficacy? I don't need to know if it's acceptance is an issue or self-efficacy is the issue, but I just need to know if there's an issue with, related to the positive aspects. So what we did then was use a method called item response theory. This is a way that SAT tests are developed, that promise measures are developed, that essentially is a different way of identifying items that measure these characteristics really, really well. And so we developed these tools. There are 3 of them, and each of the tools one of them measures negative mood, one measures sort of negative pain coping, and then the other measures more of a self-efficacy or positive affect characteristic. So these are probably a little better designed for treatment monitoring. The OSPRO, as the name implies, is a screening tool. So it's really designed to help identify even maybe the need for further assessment. These tools are designed a little bit more to give a little more precise estimate of how people perform on these domains. And so that's really one of the next, I think, steps. We're trying to understand how do you use that information in practice, and really how do we use OSPRO in practice? How can we provide further direction for OSPRO as well? I'll mention one more thing and then turn it over to Steve. One of the other areas that I think we've seen a lot of interest recently is internationally. The questionnaire has been translated already into Japanese. I know it's there are groups that are working on translations to Portuguese, German, Spanish, Italian. So I think there's a lot of interest internationally on number one, translating the tool, but then also understanding how it performs outside of the U.S. So those are a few areas that I think we're working on and excited about next.
Yeah, I think just the measurement aspect Trevor hit on. I think some of both kind of the IRT versions or companions, and then the cultural adaptations. And then I think the implementation part is something, in a lot of ways that ball was hit into our court. And I think we're trying to figure out how we, might be able to hit that back. What are there thresholds that can help with decision making, or indicate that maybe more psychologically informed care would be indicated? Is there like an extreme level that would suggest co-treatment or involving mental health provider? So I think that implementation part remains a focus, and that's a challenge because there's just you find there's a lot of variability in clinic practices, and so at that point it becomes a little less about the tool, even though that's the measurement vehicle, and more about what are the cultures and the practices of the people that want to use this, and how can we kind of adapt to that and both get to the same goal, which is better outcomes for the people seeking care.
Save the date for the 2024 AAOMPT Conference, October 23rd to the 27th in Orlando, Florida. Join OMPT professionals for 5 days of continuing education focused on OMPT, hands-on learning, research, networking, and more. Visit AAOMPT.org for more information.
So last thing we'll ask, and hopefully we can answer this one. You mentioned outcomes. Can we answer that? How does early identification of psychological risk factors with the OSPRO-YF like that lead to better long-term outcomes for patients?
Well, I think the clearest thing we can say at this point in time is the best use of it is probably it gives you an indication who's likely not to have a good outcome. And then there are some things that you can do along the way to hopefully change that course. I mean, it is an identification tool. It is meant to kind of let you know there may be some beliefs or thoughts or behaviors that could be predictive of a poor outcome, and this gives you a chance to address those. I think marrying the treatment, whether it's with OSPRO or any of the screening tools, has been a little bit more challenging.
Sure.
And that's a whole separate other podcast.
Mm-hmm.
But I think just the awareness to be able to say this person may be predisposed, what are some things I can do, versus later on saying, well, that person had a bad outcome because of that. That's really where the OSPRO is. And hopefully, in the future, we can provide more definitive. I think that's, Trevor's work in the phenotypes is really, I think, plays to the strengths of this tool, because it gets away from a high, medium, low risk model to more of someone that maybe needs lots of attention in self-efficacy. They may have low confidence, or someone who is distressed just with negative mood. And I think the OSPRO allows for a little more refinement of that to do matching treatment. We haven't tested the effectiveness of that match treatment yet. We're just kind of getting our head around what those phenotypes look like. And they do look different than the traditional, high, medium, low risk.
All right, last thing we do on the show is words of wisdom. Is there anything you guys would want to wrap up with, leave with the audience?
Steve, you want to go first or last?
I don't know. We've tried to do some words of wisdom along the way, I think. I don't know. Go ahead, Trevor.
Yeah, I think I sort of already mentioned it, but it may be worth, again, leaving listeners with this, is that, there is, I think, some value in opening up some of these discussions with patients. On that last question that you asked, Jimmy, I think one of the other outcomes that we, maybe don't often pay attention to is satisfaction with care and rapport. And, purely anecdotally, what we hear from some of the therapists that are using it here at Duke is that, by having some of these discussions, patients now recognize that that you really do care about them at the whole person level. It's not just caring about their knee, and once their knee's better, then you're gone. It's really caring about the entire person. And if this is one of the ways to get patients to understand that and to really understand what the whole person needs, then that's really a great opportunity. And so I think that's where a lot of the physical therapists that have used this see the benefit, is that it really helps to improve the quality of the communication with patients beyond what it may drive specifically about the type of psychologically informed intervention that you're doing, or the fact that you may refer them outside of physical therapy. It's really about the quality of care that you're providing. So I'll leave with that.
Yeah, usually the second words of wisdom is better because the person's had time to think about it, or reflect. But I think
right here.
Yeah, Trevor did a really nice job. It'll be a hard part. I mean, I guess just going all the way back to the origin is, I think there's, the words of wisdom with something like this is there's the things we could have predicted and the things that we couldn't have predicted that would have happened once we started down this line of research. And I think just being open to, it's a balance between having the vision, but also being open to feedback. And I think, for people that are, this is maybe a little bit beyond, just the use of this tool, just the flexibility to be open to that, I think was really key to this line of research, where we had an idea of where we wanted to go. But we also were very, it was malleable enough that we could receive some of the input and still, use it to inform kind of where we are now with the tool. A lot of the things that we did as follow-up were really based on feedback we received. And so it's more of a kind of a Zen words of wisdom, whether you're doing research or starting a new QI project in your clinic and using this, definitely have in mind what you want to get out of it, but be open to things that are going to kind of evolve, because you're perturbating the system, right? You're perturbating something, and there's going to be some things that you expected, but then there's going to be some other things. When you shake the tree, there's you hope the fruit falls down, but there might be something else in there, that either could claw your eyes out, or it could be something that is quite helpful. And I think we towed the line with a really, really good team, and appreciate the opportunity to talk a little bit about it. And, certainly gives us the motivation to keep moving on this, again, with the really the thought being of driving this into practice so that it can, the people that need this will benefit from the therapist and the other people that are using it.
Well, thanks for being a part of creating a team that created a tool like this. And thanks for taking some time.
Yeah, we should probably give a shout out to the other folks. So it was Sam. I mentioned Sam Youngfing, who was the two statisticians. Trevor will correct me if I'm wrong. Trevor, of course. Jason Benachek, Giorgio Zeppieri, Joel Bialowski. I think were all the folks. Am I forgetting anyone? I should probably pull up the paper just to make sure. But those were all the folks, involved with the original proposal and involved with the grant application to AOPT and things like that. So it was a really, really good team. And we continue to work with most of them.
Great. Well, thanks for sharing here on Orthostatic, and thanks for doing what you do.